Hello, everyone, and thank you so much for joining us tonight for this educational webinar. My name is Michael York, and I will be your moderator for this evening. If at any point we like to make this interactive, if you do happen to have questions, please go ahead and utilize the question and answer function down below, or you can use the chat, whichever one you prefer. You can go ahead and utilize those throughout tonight's webinar. We'll take some questions during the middle, and we'll take some questions at the end as well. But we're so glad that you were able to join us tonight. Tonight's webinar is on age-related macular degeneration, or ARMD, and it'll be presented by our very own Dr. Sonia Dhoot. Dr. Dhoot is a medical and surgical retina specialist with Harvard Eye Associates, so obviously has an extensive knowledge on tonight's topic. First, a little bit about Dr. Dhoot. She attended the Rensselaer Polytechnic Institute and Albee Medical College for an accelerated undergrad and medical school program, after which Dr. Dhoot then completed her residency and 2 years of vitreoretinal surgery fellowship at the University of Missouri. So we are so glad to have Dr. Dhoot not only with us tonight, but as a huge part of the Harvard Eye family. And so without further ado, I will pass things along to Dr. Dhoot.
Thank you, Michael. And thank you all for joining us this evening. We used to do these webinars in person, and so it feels a little bit just informal and impersonal, I guess I should say, doing it on Zoom. And so please feel free to ask questions. We really want to make this a learning experience for all of you, whether it's you or your family member or loved one that has macular degeneration. We want this to be an educational experience for you. So please feel free to interrupt. Michael will interrupt me with questions, and we'll stop to take some questions at the very end as well. Like Michael said, I'm Dr. Dhoot. For those of you who don't know me, I am a medical and surgical retina specialist, and my partner, Dr. Brian Kim, also treats macular degeneration. So I'm sure if you're not familiar with me, you may be familiar with him. So I'm just going to go ahead and get started. These are my financial disclosures. So, I think one of the big fears about hearing the word macular degeneration is the fear of blindness. And that's, obviously probably why a lot of you are listening tonight. And that's the first thing that I want to dispel is no matter how advanced your macular degeneration, you or your loved one will never wake up fully blind. You'll never wake up completely black just from macular degeneration. So macular degeneration in its advanced stages affects only the central vision. So anything we're talking about here on out is really just central vision loss. So this is a picture of a retina. Many of you probably recognize this. On the left-hand side of here on the screen, that is the circle, that is your optic nerve, that is basically the cable that connects your eyeball to the brain. Everything you see goes through that optic nerve, gets transmitted to the brain for processing for us to be able to see. And then there's the arteries and the veins that emanate from the optic nerve. And really what we're going to be focusing on is that circle to the right of that area called the macula, and the centralmost portion of the macula is a very, very tiny area called the fovea. So you can see from here, the macula is a very anatomically small area of the retina, but it's very important because it has all of our color sensing cells and all of this cells that are responsible for our central vision. So what does someone with any macular problems see? Well, you can see kind of like a black or gray spot in the center of your vision, like in this picture here. You'll also notice that both of those buildings look a little wonky. This is not some weird picture. This is actually just distortion. So people with macular problems, a lot of times straight lines will start looking wavy to them. And that's one of the first signs that there could be either macular degeneration or some sort of process happening in the macula that's affecting your ability to sense straight lines. More advanced stages of macular degeneration look like this. So you can see, looking at this picture, you can make out it's a picture of a family, and there's a mom and a dad, and probably 2 children, but can't really make out their faces too well. And that's kind of one of the complaints that we hear most is people with macular degeneration can see. But for example, if a person is approaching them, they know there's a person approaching them, but they can't tell who it is because they can't make out the face. If they're looking at a clock, they're able to see kind of usually the numbers on the clock, but they can't see where the clock hands are pointed because that's their central vision. Central vision is also very important, more so than peripheral vision when it comes to reading. And so reading difficulty is one of the things that patients with macular degeneration struggle with much more than distance vision. So the World Health Organization in 2023 listed the most common causes of blindness in the world. And so these are in order of prevalence. So refractive error means needing glasses, cataract. Both of those two are easy problems to solve, either with glasses or surgery. And then the bottom 3 are much more difficult. So diabetes, glaucoma, and then of course macular degeneration which is what we'll be delving into more detail today. So in North America, these statistics are a little old. They only update them every so many years. But over the age of 40, 12.6% of the population has macular degeneration. There's 2 types of macular degeneration, which we'll get into a little bit more in a few minutes here. The dry type of macular degeneration, which is typically the better of the 2 to have. 90% of people have that form, and then 10% of people have the wet macular degeneration. And because our population just continues to age, modern medicine has gotten so much better, so people are living longer and longer. We expect these numbers to increase 1.2 times by 2030. So this is just a graph that shows the prevalence of macular degeneration by both sex and ethnicity. And for whatever reason, we know that macular degeneration tends to affect Caucasians more commonly than people with other ethnic backgrounds. And we think that's just because they tend to have lighter colored eyes. And then also there's just a large hereditary component. So that's probably part of it as well. Another graph showing across the different ethnic populations, how we expect these numbers to just keep growing as our population continues to age. So interestingly, some people say that macular degeneration affects males more, but I think most studies say that it affects females 65% more, or 65% compared to 35% in males. And again, we're not 100% sure why that is. So who gets macular degeneration? I mean, the 2 big ones are family history and age. And of course, unfortunately, neither of those are anything that we can control. Like I mentioned earlier, having a lighter iris color, so blue eyes, green eyes, those people tend to develop macular degeneration at higher rates. And then we talked about females and Caucasians. Now, the modifiable risk factors, we know that if you have ever been a smoker, whether currently or previously, you are at 2.5 to 4.5 higher chance of developing macular degeneration. And if you have macular degeneration and are currently a smoker, we know that you will lose vision faster and you won't see as well as someone with the exact same risk factors who's not a smoker. So you really would be, that's the biggest thing, is doing yourself a huge, huge disservice if you have macular degeneration and you're a smoker. And then all of those things that are also good for your heart, cardiovascular health, are also good for your eyes. So high blood pressure, elevated cholesterol, a diet high in fats, a sedentary lifestyle, obesity, all of those things are also higher risk for macular degeneration development and progression. So I'd say, every so often now that genetic testing has become more prevalent, patients ask all the time, well, should we just get genetic testing to see what our risks are? The American Academy of Ophthalmology released a statement in response to these questions. And at this current time, they're recommending avoiding routine genetic testing for macular degeneration. And the reason for that is because we know it tends to run in families. And if you are already at higher risk, unfortunately, there's not really a whole lot we can do other than tell you don't smoke and try to live a healthy lifestyle, which we pretty much advocate to all of our patients anyways. So unfortunately, knowing that you're at higher risk for macular degeneration at this time, there's nothing that we can do for it. So the Academy hasn't recommended routine testing for those patients. There's really no screening guidelines recommended other than just annual vision checks with your eye doctor. A lot of optometrists will do screening retinal photographs, such as this one. This is your entire retina, so it's much more zoomed out than the first picture I showed. And so the macula is that small little dot right there in the center. So you can see just how small that area is. And then usually if the optometrist has any concern based on what these pictures look like, then they will recommend evaluation with a retina specialist to determine whether you have the diagnosis or not. Ultimately, to make the diagnosis, we do need to do a dilated eye exam where we put dilating drops in to make your pupil larger and take a very detailed look at the macula. And that's much more sensitive than the photographs. The photographs, as you could tell on the last slide, can miss things that are very small because it's such a large photograph. And when we look back there, we're getting a 3D magnified image of your retina. And so there's unfortunately still no substitute for just doing a good eye exam. Sometimes we will get testing known as fluorescein angiography. What this is, it's basically a test where we inject a vegetable-based dye in your vein in the office to see what's going on with the blood flow in the back of the eye. This dye circulates in the blood vessels all over your body, but as it's circulating in the back of the eye, we take photographs, and the way that dye behaves gives us information as to, is there dry macular degeneration, is there wet macular degeneration, and oftentimes this test is not needed, but sometimes in cases where it's really early and we're not sure if it's wet macular degeneration, then the dye test helps us quite a bit to try to figure out what exactly is going on in the back of the retina. More often, and those of you who see a retina specialist are probably very, very familiar with these pictures. These are scans called optical coherence tomography, or OCT. This is a non-invasive test that we do in the office, and it's very quick. It takes about 5 seconds to do in each eye, and it gives us very detailed imaging of all of the layers of the retina. So there's 10 layers of the retina, and then it's also imaging the blood vessels underneath the retina. And so, depending on what's going on, these scans will kind of let us figure out where the pathology is and how we treat it. So the top picture is a normal OCT scan, and the one below is a patient that has wet macular degeneration. There's a little hump, and then to the right of that hump, there's a little black sliver, and that is fluid that's accumulating underneath the retina. And so that is a patient with wet macular degeneration. So what is macular degeneration? I know, we've touched on it over and over, but basically your macula is aging faster than you are. So dry macular degeneration is when you get these lumps of calcium that build up underneath your retina, like on the left side picture. Those little lumps are called drusen, and they are a hallmark of dry macular degeneration. About 10 to 15% of people at some point in their life will convert from dry macular degeneration to wet. And so if you look at the picture on the right, I mentioned earlier, there's a layer of blood vessels underneath the retina called the choroid. You can get new blood vessels from that choroid, break through that green layer, which is called the retina pigment epithelium, and start developing into and underneath the retina. And those blood vessels are not healthy. They will bleed, they will cause fluid. And once that happens, you have basically been diagnosed with wet macular degeneration, and that needs urgent treatment. My partner, Dr. Kim, likes this photograph. He likes to say that dry macular degeneration is like the tread on your tires. Slowly gets worse with age. If your macular degeneration turns wet, it's like running out of gas. It gets worse very quickly. So oftentimes we'll have patients who don't even know they have macular degeneration because they have the dry type, and their vision's pretty good and they're progressing pretty slowly, so they are humming along, not realizing they have any problems. And then all of a sudden they wake up one morning and they can't see out of the center of one eye, and that's when they convert to wet. And unfortunately, that's sometimes the first time that we see them in the office and they didn't even know they had macular degeneration. So unfortunately, that's not an uncommon story. Can be prevented with just making sure you're getting your yearly eye exams. So again, on the left, that's a picture of a normal retina. On the right, kind of hard to see, but in that center area there's some tiny little yellow dots, and those are the drusen, or those calcium deposits I was talking about. Just seeing those drusen doesn't necessarily mean you have macular degeneration. We see plenty of young, healthy people that have drusen and don't necessarily have macular degeneration. So again, on the left is a normal, and then you can see those calcium deposits are really starting to be more numerous in that right-handed picture. And so this patient has early dry macular degeneration. Again, normal, and you can see this is now an intermediate stage of dry macular degeneration, even more yellow deposits. You're starting to get some changes of that RPE, which is that layer, the retina pigment epithelial layer underneath the retina. So that once that film starts getting, or once that layer starts getting abnormal, then we start calling it intermediate form of dry macular degeneration. And although I said that dry macular degeneration typically is the more preferred or the better of the two, in advanced stages, dry macular degeneration can also cause pretty severe central vision loss. And this picture here on the right, you can see, you don't really see those drusen deposits anymore, but actually you see kind of like a yellow spot. The spot here in the middle, it looks like a huge chunk of the retina is missing. This is what is known as geographic atrophy. And this is the most advanced stage of the dry macular degeneration. And this patient probably also has very, very poor vision in the center, even though it's not wet. And this is now end stage dry macular degeneration. And you can see on that right there, all of those big, what look like blood vessels. That's actually the choroid, which is that layer of blood vessels underneath the retina. The RPE layer, which separates usually the retina from those blood vessels, is so far damaged that it's totally gone. So you can actually see through into the choroid there because there's just so much damage. It's like that whole area is just gone. It's eaten up. And so you can actually see layers underneath the retina that you're not supposed to be seeing. And so this patient also has very poor central vision. So this OCT, if you take an OCT through a patient with dry macular degeneration, on the bottom, so the top is normal, on the bottom you see kind of that lumpy, bumpy appearance, and those are the drusen that we actually see on the OCT correlating with dry macular degeneration. So now this is a patient with wet macular degeneration. You can see there's a large hemorrhage in the picture on the left. That's a telltale sign that the macular degeneration has turned wet. However, you can have wet macular degeneration without actually having a hemorrhage. You can just have fluid on the OCT, like on the bottom right picture, without actually having a hemorrhage. So both of those, with or without the hemorrhage, would be classified as wet macular degeneration. In advanced stages, so if you don't treat the wet macular degeneration, it basically just scars down. And so this patient has a large scar in the center of their retina. And if it gets to this point, unfortunately, there's nothing we can do to save the vision. This is now the advanced stage. And at this point, the goal of therapy would be to focus on the other eye, and hopefully there's visual potential there because this eye is too far gone for treatment. So we keep referencing treatment. What is the treatment? it's kind of slow. It's akin to what would slow down aging, because that's ultimately what this is, right? It's an aging process of the eye. So like we mentioned before, all of those things that are bad for you overall with aging, excessive drinking, cigarette smoking, we know those are going to make your macular degeneration progress faster. The picture on the left, green leafy vegetables, high in antioxidants, kale, Brussels sprouts, collard greens, all that stuff no one likes. But I'm sure your cardiologist tells you is good for you. Same thing is good for the eyes. Whereas that greasy burger on the right, no matter how juicy and delicious it looks, not good for your coronary arteries and definitely not good for your eyes either. And then exercise, we touched on that earlier as well. So the AREDS2 vitamins, so they have looked extensively at what vitamins help slow down the progression of macular degeneration. And they've looked at who should be taking those vitamins. Do we give it to everybody? So all of the studies have shown that in patients that have wet macular degeneration in one eye and dry macular degeneration in the other eye, taking these AREDS2 vitamins, which are pictured up on the top right, slow down or reduce the chance that the dry macular degeneration eye turns wet by about 27 to 30%. Patients that just have dry macular degeneration in both eyes, patients whose parents have macular degeneration, but they don't have it, all of the studies have shown that the AREDS vitamins don't affect those patients for the better or the worse. However, because they're basically just high dose vitamins, we do recommend all of our patients with macular degeneration to take an AREDS2 vitamin, because the risk of taking it is pretty low. And the benefit is potentially warding off wet macular degeneration. But you look straight at if you look just at the studies, that's what the statistics show. Dark green veggies, like we talked about, fresh fish, which is also high in antioxidants, is recommended 3 times a week. And then, we talked about no smoking, exercise, blood pressure, cholesterol control. Really, all of our dry macular degeneration patients, the biggest thing is monitoring, because the sooner we catch wet macular degeneration and jump on treatment, the better. And so, patients are given an Amsler grid, which on the right is what it looks like. And what we're looking for is straight lines looking wavy, like in that picture I showed you at the beginning, black or gray spots there that are not normally present. Those are all things we need to hear about. The big thing is actually checking each eye once or twice a week. I can't tell you how many times people have a large bleed, lose vision in one eye. The other eye is normal, so they walk around not realizing they have a problem. And then unfortunately, it's not till they come into our office that we cover one eye and they go, oh my gosh, I didn't realize I didn't have vision in that eye. And that's because with both eyes open, their good eye is compensating. So there's also recently, since the advent of COVID and things have been pushed more and more remotely, an option to do remote patient monitoring, which is a website that patients log into about once a week. And it's an electronic version of this grid. And if there's any changes in their responses, the company actually will email the doctor so that we can bring them back and hopefully catch any wet macular degeneration conversion sooner rather than later. In general, because reading is more difficult because we're relying so much on our central vision to read, reading is the thing that we hear the most about challenges. So we recommend bright lights. Reading a small print menu in a dimly lit restaurant is the worst. So lots of bright lights, magnifying glasses. Tablets are really nice if you can have family help you use one and get comfortable with one. Almost everything nowadays, literature-wise, is available in in either like an e-reader or on the tablet. And so the tablets are nice because you can actually change the contrast between the background and the text font. And you can also blow up the font so that you can see things, basically make it as ideal as possible for you to be able to read. There are low vision optometrists that can kind of figure out what you're having the most difficulty with and try to give you telescopes or that sort of thing to get you to do what you want to do with as little difficulty as possible. But really what it boils down to is that early detection of wet macular degeneration is what's going to save your vision. This is again another picture of a patient who has a large hemorrhage in their macula from wet macular degeneration and would benefit from starting treatment ASAP. So in the past, maybe 20, 25 years ago, the only options were really, whenever you had wet macular degeneration, was just to laser the macula. And lasering the macula basically just burns the entire thing, new blood vessels and the macula. So it was a great way to stop bleeding, but it was also damaging healthy macula and leaving patients with not such great vision. Since then, we've come a really, really long way. And so I'm sure you all have at least heard of somebody getting injections in their eye for wet macular degeneration. And so we've come a long way. And every couple of years, there's new medications that are released for wet macular degeneration treatment. And these are all of the drugs that are currently available to us on the market today. Last year, there was a surgical implant that was FDA approved, which has since actually been removed from the market because of some safety concerns. But this was actually surgery where a little device was implanted into the eye and then refilled in the office with the goal of reducing the burden of injection treatments. These are some OCT scans of patients with wet macular degeneration. The top two images, the patient has some fluid and their vision was about 20/70. And then on the bottom, you can see that same patient after injections, excuse me, the fluid has resolved and their vision has returned to 20/25, so pretty good. So, dry macular degeneration slowly gets worse. Wet macular degeneration, yes, it's like running out of gas, but it's not like you fill up with gas once and you're done. We very specifically use the word treatment and not cure. And the reason we say that is because the shots work great as long as we administer them. Unfortunately, they have to be given at regular intervals, just like filling your car up with gas. And so just like your blood pressure medication or your diabetes medication, they work great when you're taking them. But what happens if you stop? Your blood pressure goes back up, your sugars go back up. And so same sort of thing with wet macular degeneration. You stop the injections, it's just a matter of time before you will have another bleed and potentially lose vision permanently. In really advanced stages, like the one on the bottom right here, that patient has a very, very large hemorrhage. And so there's been treatments aimed at trying to figure out how to drain that blood to get patients to see better surgically. And unfortunately, nothing has panned out to be too helpful as of yet. So we kind of talked about living with severe macular degeneration. A lot of that can be facilitated by co-managing with your optometrist. So as of last year, we would basically talk about therapies with wet macular degeneration, and that was it. We didn't really have any treatments for wet or dry macular degeneration. We don't really have a treatment for dry macular degeneration, but geographic atrophy, which is those areas of loss of the RPE where you are slowly getting into the more advanced stages of the dry macular degeneration, usually starts right off to the side of the macula, and with time will involve the fovea. And once it involves the center or the fovea, that's when you lose permanent vision. So geographic atrophy affects about 20% of patients with macular degeneration, and it can cause severe vision loss. So this is kind of a diagram of what that looks like. So on the very first picture, you can see that yellow area is that area where you're starting to lose the RPE cells. And then you can see that lesion progress until in the far right, it's completely involved the center and vision has been lost. So before last year, there was really nothing we could do. We would just watch those lesions grow and watch patients lose their central vision right in front of our eyes. Last year, there were 2 drugs that were approved by the FDA called Syfovre and Izervay. And both of those drugs are work on the complement cascade, which we know makes those geographic atrophy lesions grow. So these are also injections that are administered between every 4 to 8 weeks. And they don't improve the vision, but they slow down how fast those geographic atrophy lesions grow by about 30%. So if we see someone who's healthy that we know is going to be around for a while, and they have that geographic atrophy lesion that's approaching the center, then we'll have a discussion with them about potentially giving them a few more months to years of vision with starting treatment with either of these medications. What's next? We are constantly looking for new therapies in both wet and dry macular degeneration. Harvard Eye Associates is part of a phase 3 clinical trial for wet macular degeneration. We're actually, we're still currently enrolling, but I don't think for too much longer. But what we're looking at in this study is a new drug that will help our current medications last a little bit longer. So really the biggest burden with wet macular degeneration treatment is how often we have to administer it. So we have so many different options of different drugs we can use, but the average for all people across the country is about every 6 weeks they need injections. So that's still pretty often. So all of our research is looking at how do we get those drugs to work better and longer so patients don't have to come in as often to get injections. And so for this study, we are only enrolling patients who've never had injections before for wet macular degeneration, and they get Lucentis, which is a medication that we already inject for wet macular degeneration, with potentially an adjuvant of this new molecule to see if it's going to work a little bit better and longer. So I'm tired of hearing myself talk. And these are a picture of my 3 little kids just a couple of months ago here. But I want to pause to see if anyone has any more questions, to see if we can open this up to talk more about specific things that you guys are interested in or have questions about.
Yeah, thank you so much, Dr. Dhoot. And like Dr. Dhoot said, please go ahead and feel free to utilize the question and answer function down below. And also the chat. Let's stay away from the hand raising because that hand raising function tends to bring up a lot of technical difficulties. So please go ahead and utilize the Q&A or chat function down below. Also, if you're anything like me and there's something, I would love to rewatch this again, or you know what, I have a family member who would love to see this. We do actually send a recording of this video to everybody who registered for tonight's webinar. Not only that, but you can actually access it through our YouTube channel as well, where there's also a lot of great and wonderful presentations just like tonight's. So you can feel free to visit that page as well. And we do have a great question. How was AMD discovered?
Oh, that's a good question.
Yeah.
I think a lot of people will tell me that they don't know if they have a family history or they don't think they did. And I think that's just because we didn't know much about it at the time and people weren't living as long. So people may have had it in their genes, but people were either passing away sooner than they would have been diagnosed, or there was just no way to diagnose it. I think once we were able to actually start visualizing the retina, we were able to start, realizing this was a problem. I don't have a really great answer of like, it was discovered one day in a dark lab or anything like that. But I think it was just like, as people got older and were experiencing this and we were able to visualize the retina, it became something we were able to look at and treat.
Yeah, just more consistent screening. And yeah, I would imagine as well as a way to kind of tell the advancements of AMD. And this is a great question. Can cataract surgery or any other surgery for that matter make dry AMD worse?
That's a great question.
Yeah.
So dry AMD, no, but patients with wet macular degeneration, we want to be stabilized and have the fluid gone because certainly having surgery can activate it again. And so, we have a lot of patients that sometimes have to wait months before we can get their fluid to go away, before we can finally send them to the cataract surgeon so that they can have their cataract out. So ideally, we like the wet to be stabilized, but the dry, it does not increase your risk of conversion to wet, no.
Would there be, and this is kind of an altered follow-up to that question, but is there potentially a preferred lens to a patient with wet macular degeneration that
Yeah,
you?
good question. So there's lots of different lenses, and there's always new ones coming on the market every couple of months. I feel like I can't even keep up with all of them anymore. But basically, we know any of the premium lenses, which are kind of the fancier lenses that are aimed at trying to get your distance and your reading vision all fixed with cataract surgery. Those are not ideal for patients with macular degeneration, and that's just because different parts of the lens are aimed at different focal points. So for example, they'll have rings on them for maybe the outer ring being for distance and the central ring being for reading. And if you're not able to utilize your central ring, then you're not really going to be able to appreciate the full capacity of what that lens has to offer. So patients with macular degeneration, we typically recommend them just getting the standard monofocal lens, whether they get corrected for just distance or just for reading. And then, oftentimes reading glasses are needed as well.
Mhm. How about something like the LAL? Would that be come into effect given its
Yeah, and
feasibility?
that's something that we have discussed quite a bit because the LAL for those of you that don't know, is a light adjustable lens, and so it's pretty neat. It's a lens that corrects you for one distance, but it's aimed at getting your vision precise just for you. If you go out and buy shoes, you can buy a size 10 and you can buy a 10 and a half, and maybe the 10 is slightly too small and the 10 and a half is slightly too big. And it's very similar when you're looking at cataract lenses. And so what the LAL does is it basically tailors that lens just to you. And the way that they do that is after they put the lens in, afterwards in the office, they use a laser to adjust it based on your prescription. And so there was some thought that maybe using that laser could potentially be damaging the retina. But so far, all of our studies have shown that it's safe. And so if you have really advanced macular degeneration, probably still not a good option for you. But I think for the very, very early stages, I think it's a good option.
What's the effect of dry eyes on a patient with AMD?
No, dry eyes are very, very common as we get older. Hormones, heaters, just normal environmental factors can make eyes dry out. Certain medications can do it. So it's very, very common in the aging population. And so certainly dry eyes can affect your vision. It's like driving with a cracked windshield, right? So you want your tear film to be nice and smooth. And if it's not smooth, your vision is going to be impaired. So it's important to treat the dry eye for the sake of comfort because it can be very, very uncomfortable, and to optimize vision, but it actually has no effect on macular degeneration itself. Patients who get injections in general, their dry eye does tend to get worse. So we just have to make sure we're staying on top of that treatment, treating their dry eye as well.
And then another good question, and I do you need to have macular degeneration to take AREDS 2 or eye caps, or can they be taken preventatively?
So you can take it without having macular degeneration. It's not going to do anything like harmful to you. They aren't cheap. So I tell patients if you want to spend the money on them, it's not going to harm anything. But all of the studies have shown it's not going to reduce your chance of developing macular degeneration. So I usually tell people if they have a strong family history to just take like a Centrum Silver daily multivitamin instead.
And then we have kind of two separate questions that are in the same category, and we might be a little biased about this one. But are you familiar with the new Oculus goggles and headsets, and or have you heard of Idaptic's EI2? And to help patients with AMD read and watch TV, and kind of how do they work?
Yeah, so Idaptic, we actually sell in our office. So I have some personal experience with that. And for patients who are good candidates, it works great. And we know it works if you get it before your vision is too far gone, because then you learn to use the glasses. And then as your disease progresses, they become more and more helpful for you. So basically, they're aiming at helping magnify, helping move an image out of the spot that you can't see and into a spot that you can see. Typically, patients that are seeing like 20/60 or 20/70 or worse in their better seeing eye are patients that will benefit from it. And ideally patients that don't have like severe glaucoma, because if you have glaucoma on top of macular degeneration, you have other visual field problems. It's harder to shift that image out of the area that you can't see into an area that you can see. So patients that have glaucoma, it's not going to be as helpful. But for the right patient, it's been life-changing. So if you're interested at all, we would have you come into our office to see any of our optometrists. They would do a good prescription check for you. And then we have one person in our optical department who just does eidaptic screenings. And so she would spend some time with you figuring out whether it would be a good option for you, helping you kind of try it on and see how it functions for you, and then kind of go over the payment options.
Yeah. And then this is kind of a two-part question as well, but what are the odds, or are there specific odds that one were to have AMD if they have a family history of it? And then is AMD intensified, or is there a higher chance of you getting it if you have a family history of retinal detachments or tears or retinal issues?
What was the first part of that question?
Is there a certain odds that if you have family history of AMD, is there a certain amount of odds or percentage that you're the likelihood that you were to get it as well?
Got it. So, some diseases are like what we call autosomal dominant or autosomal recessive, meaning, if you have one parent that has it, there's a 50% chance you're going to get it or something like that. And unfortunately, macular degeneration is not that. It's multifactorial, meaning there's lots of things that play into it, mainly, the things that we watched out for or that we talked about. We know it is strongly hereditary, but we don't have a percentage. And that's just because there's not just one mode of inheritance. There's so much that goes into it. And so, I tell patients who have children that are afraid of this, just make sure you're really emphasizing a healthy lifestyle, not smoking, just taking care of yourself. But yeah, unfortunately, there's no no specific number. And then in terms of retinal detachments, so yes, retinal detachments can be hereditary to some degree as well, but no relationship between having a hereditary retinal detachment and macular degeneration, different diseases.
And it looks like those are all the questions that we have. And then if any do populate, and we have actually one more, so we'll answer this one last one. If you have any intermediate dry AMD, what are the chances it becomes wet, and after how long? How long does that process usually take?
Yeah, so that's a hard question to answer. You can go from, like I said, I've had patients that didn't even know they had macular degeneration. They're like early in one eye, and then they have a large bleed in the other eye. So it doesn't necessarily go early, intermediate, advanced, wet. It doesn't necessarily follow that path. And so it makes it really challenging to figure out what the timeline is going to be. I tell people you can live the rest of your life with intermediate dry macular degeneration. You can die with it that way, or you could wake up tomorrow and it'll be wet. So there's really just no way to know. I know that's a little disconcerting, and it's not meant to be. It's just a matter of making sure you're keeping on top of your vision. And if anything just doesn't seem right, to call us right away. But yeah, there's no like, okay, well, in 3 years, you're going to start needing injections. There's just no way to predict that.
Yeah. And thank you so much, everybody, for your fantastic questions. If you're anything like me, where it takes a minute to process the information and then you come up with questions later, you can always call our patient support line. They are amazing, and they will be able to point you in the right direction and answer any questions you may have, or help set up a consultation with Dr. Dhoot or Dr. Kim, both of our retina specialists. That number is simply 949-951-2020. You can also find it on our website or Yelp or what have you, or on Google. So they are wonderful, and they will absolutely be able to help you with any questions that might come up later in the days to follow or weeks to follow. And yeah, just like I said, we're so glad that everybody could join us this evening for another wonderful webinar. Thank you to Dr. Dhoot so very much. Again, you can rewatch this on YouTube, and it will be emailed to you as well. But before we close, Dr. Dhoot, any last words?
No, thank you all for spending your evening with us. And hopefully we can get back to doing these in person soon. It's nice to be able to like see our patients and their families and be able to interact with you guys in person. But if not, we look forward to seeing you in the office, and feel free to reach out if you have any questions. Thank you all so much.
Yeah. Thank you, everyone. Have a great rest of your evening. Take care.